Hello and welcome to my lecture on pulmonary embolism. Now before we start this lecture, there are certain disclosures. All the material which were used in this lecture are our own. There may be certain material which is downloaded from the net, but we have confirmed it as a royalty free. We acknowledge with thanks from those whom we have got this material. This is our own publication on CT Pulmonary Angiography. It was published in an international journal by our department. Today's lecture is based on that with some additional cases which you will see other than what we have published in a journal. So cases in this are fresh. Now let us go to the introduction of the presentation. These are the basic unit of the lung. Now let us understand what is physiological changes taking place. There is acute and complete pulmonary thromboembolism resulting into alveolar dead space. So this is what pathogenesis it makes. Now if you see the lower image, you will see all the alveoli are obliterated by the blood. So there will not be any exchange of oxygen taking place in these two. Therefore ventilation is continued in the areas of lung, particularly in bronchiole. However, there will not be any exchange of the oxygen. So this is important thing to understand how a pulmonary embolism affects it. Now hemodynamic consequences are at least 50% of the pulmonary vasculature should be obstructed before an increase in pulmonary arterial pressure sets in. Now emboli form undergoes lysis, fragmentation, or become organized and undergo their subsequently canalization. This is a fate of any blood clot. Now repeated thromboembolic episode without complete lysis may lead to pulmonary arterial hypertension. But as I told you, it has to be more than 50%. Now pulmonary embolism is a blockage of main pulmonary artery of the lung or one of its branches by a substance that has traveled from elsewhere in the body through the bloodstream. That is called as embolus. Now pulmonary embolism most commonly result from deep vein thrombosis, that is the calf muscle from where the thrombosis is. A blood clot in deep vein of the leg or a pelvis that breaks off and migrates to the lungs. This process is termed as venous thromboembolism. Now a small portion of cases are caused by embolization of air, fat, talc in drugs of intravenous drug abuse. So that's not very common in our country. The symptoms and signs of pulmonary embolisms are due to the obstruction of blood flow through the lungs resulting into high pressure on the right ventricle of the heart. The risk of pulmonary embolism is increased in situations like cancer or prolonged bed rest. In these patients, one has to take care that there will not be embolization. Most common symptoms are dyspnea, then pleuritic chest pain, coughing, and hemoptysis. Then there are also atypical presentation like abdominal pain, pelvic pain, then decreasing level of consciousness, fever, productive cough, seizure, syncope, and wheezing. These are some additional symptoms which we come across. Now what are the risk factors? Is AIDS, HIV, then antithrombin 3 deficiency, Brackett's disease, blood type A, burns, indwelling venous catheters, pacemaker, chemotherapy, myocardial infarction, and history of prior deep vein thrombosis. Then oral contraceptives, then fracture, surgery, malignancy, obesity, prolonged bed rest, pregnancy, systemic lupus erythematosus, trauma, varicose veins, then venous stasis, and procedure of venography, to add a few more. Now what are risk factors for DVT and pulmonary embolism? That is the prolonged embolization, patient in case of fracture, paralysis of the limb, or a bedridden due to illness or being elderly. Now trauma and surgery are to add more. Then there are multisystemic injuries such as high impact motor vehicle accidents. Then incidence rate of DVT is approximately 58% in these. Not all patients gets it, but we have to take care because it is very high percentage, 58%. Then oral contraceptives, they can be aggravated by smoking and cause sudden death in healthy women. So one has to avoid these two things. Now in pregnancy, venous stasis can be a complication of pregnancy. It is because of the decrease in fibrinolytic functions. diseases. Now, congenital is a small fraction of the general population, about 5% of the population, who suffer chronic hypercoagulative blood condition because of the maturated factor like factor V, that is mutated factor like factor V and congenital hypercoagulopathies. Now, acquired deficiencies are seen in 10% of the young people with protein C, then protein S and antithrombin T, causing hypercoagulation. So anything that causes hypercoagulation are predisposed for all these things. Now let's go in more detail. Thromboembolic pulmonary embolism could be acute pulmonary embolism, could be chronic embolism, or they could be non-thrombotic pulmonary embolisms. Now, how you diagnose? By imaging techniques and non-imaging techniques. Now, imaging techniques include chest X-ray, very gross assessment, very crude, then ventilated perfusion scan, pulmonary arteriography, ultrasonography, spiral CT, tomography, and MRI. A combination of chest X-ray and ultrasonography is always preferred in follow-up when there is chances of DVT and there is chances of pulmonary embolism. These are cheap, economical, available, and can be repeated. Now, non-imaging are the ECG, arterial blood gases, and D-dimers. Now, what are the diagnostic modalities to go further in that? D-dimer, chest radiograph, catheter angiography, and CT angiography. These are the modalities meant for detecting pulmonary embolism. However, today's lecture only deals with CT angiography, and there are different lectures available from our side is only over the chest radiograph in pulmonary embolism. So D-dimer as a diagnostic tool, it has got false negative, false positive, then false positive are seen in pregnancy, trauma, post-operative recovery, inflammation, cancer, rheumatoid factors, and old age. The false negative D-dimers are in heparin. Now, can there be radiographic signs without PTE, without infarction? Yes. Now, radiographic sign without infarction we'll see first. Multiple small emboli or a single large embolus may not cause any alteration in vasculature. Now, if that is not the case, then it is difficult to pick on the imaging. Expected finding, in case if it occurs, is dilated pulmonary artery, as it is clear that more than 50% that area has to get affected. Then there are chronic thromboembolic diseases. Then there is marked dilatation of pulmonary artery with cardiomegaly, which is due to pulmonary arterial hypertension. Now, these are the radiographic signs of PTE, that is a false positive without infarction. So you can get in all these conditions without there is a pulmonary embolism, without there is otherwise also you can get these signs. So they are called as false negative. Now, radiographic signs of pulmonary embolism. Now we'll come to the with infarct. What are the signs? These are important from our point of view. So pulmonary embolism signs with infarction. Now, radiographic evaluation is based on the partial collapse of the affected area of the lung and hemorrhagic congestion. Then, in established pulmonary infarct, there is a shallow humpy lesion, that is Hampton's hump, which we find at the base of the lung. Then, shallow of the pulmonary infarct becomes visible in 12 to 24 hours after the embolic episode, and there is frequent involvement of lower lobe. Aseptic cavitation of the pulmonary infarct are extremely rare. So, cavitating lesion, don't think of this. Then, sterile cavitation is more common in the infarct with more than 4 cm diameter. Pulmonary infarction may result in large bloody pleural effusion. So TAP will be hemorrhagic. Now, what are the CT findings? Then there will be changes in the main arteries, male pulmonary artery, lobar arteries, segmental arteries, and segmental subarteries. These will show the changes. Now, here you are seeing there is a filling defect. So that is a direct and definitive sign is to find a filling defect in pulmonary artery. This is always seen when there is a contrast. Now, complete occlusion, if it occurs, it is complete occlusion is because of the failure to enhance the entire lumen due to a large filling defect. Then we can say there is a complete occlusion and the artery may be enlarged compared with the adjacent patent vessel. So these are the two things when we have to see a complete occlusion, like in this case. Now, acute pulmonary pulmonary embolism, first see what is a partial occlusion. Now we are seeing a radiological sign, that is a Poloman sign, railway track sign, acute angle, peripheral and intraluminal filling defects are the main signs of pulmonary embolism as we are seeing here. Now lower extremity Doppler is extremely important when you are suspecting or evaluating a case of pulmonary embolism. Often the scans are negative, but however still a simple ultrasound test can increase the suspicion, where if subsequently we have found that this patient will come with the pulmonary embolism. The symptoms are very vague, so it is really difficult sometimes to diagnose it clinically, and we have to keep these other criteria in mind. To evaluate DVT artery is investigation choice, sonography is investigation choice. Up to 40% of the patients with DVT are without PE. Serial ultrasound should be performed in patients with abnormal, that is non-diagnostic. Then scans and positive D-dimers should be performed. If one test comes negative, no harm in doing other. US should be carried out on a day as said, subsequent up to the 14th day. Day 0 is when you diagnose it, and that day you know clinically how old it is, but it is better to follow for 2 weeks. A positive US on any of these days with abnormal is a rule for a pulmonary embolism. Now negative serial scan reduces likelihood of pulmonary embolism up to 2%. Here we are saying a normal US and color Doppler, where we are seeing a DVT. Again here we are showing you DVT, thrombus, a subtotal occlusion of thrombus in a right popliteal vein is shown in the color Doppler images. Here also we are shown in color Doppler images transverse and sagittal images of color Doppler showing blood flow in femoral artery, but not in a common femoral vein. There are the arrows, and this is an indirect finding that suggests common femoral artery thrombosis. These patients are prone for embolization. Now catheter pulmonary angiography. This we are going to just see theoretically in our center. It is rarely done. Most of the time CT angiography is investigation of choice. It is a gold standard for diagnostic. However, it is invasive. The pulmonary catheter can be used therapeutically for angioplasty. So if when you are going to go for angioplasty, okay, go ahead and do it. A filling defect of sharp cutoff in a pulmonary artery branch is a finding in this contrast angiography. A negative angiogram will with magnification exclude almost pulmonary embolism chances. Here it is difficult to repeat the exam. However, in CT, again if suspected, if there is high suspicion, maybe because of the deep vein thrombosis in the leg, we can repeat CT where it is difficult here. Then increased sensitivity is obtained with a sub-selected dye injections. Then what are disadvantages? May be morbid, may result in worsening or shortening of the breath, and can cause arterial perforation. In case of technical difficulty, non-contrast spiral CT scanning may be used as the alternative where contrast cannot be used. Now what are the CT advantages? CT angiography has multiple advantages. It is non-invasive, equally effective, it can give you equally good positive rate. That is what we approved in our study. Then CT angiography is safer, non-invasive method, and therefore is preferred in our center. Now these are the two cases we are showing you. Addition to that earlier shown, here we are seeing a contrast enhanced pulmonary angiography. We are seeing pictures, and you will find here the filling defect, crescentic filling defects, which will indicate that there is pulmonary arterial thrombosis. Now this is second case. Again we are seeing contrast enhanced CT, and you are finding there is a filling defect which is indicating pulmonary arterial embolization. With that we are coming to end of lecture. So let's summarize in the form of conclusion. Majority of patients are in the age of 15 to 60. So 50 to 60 is a high prone patients. We must think of it. Then most common clinical features in respiratory distress, chest pain, hemoptysis and tachycardia. Most common risk factor is immobilization, history of surgery, history of trauma, deep vein thrombosis, obesity, contraceptives, sometimes added by the risk by the smoking. Then pulmonary embolism is major health problem that is highly treatable if diagnosed, but carries less risk, but carries high risk for morbidity and mortality if undiagnosed. So if you diagnose, less risk. If you don't diagnose, it has got very high risk, and because of the overlapping symptoms, non-specific symptoms, often it is difficult to diagnose clinically, and it repeated diagnostic autopsy. Now, radiography is a major investigation tool in finding of the pulmonary embolism, and there are several diagnostic studies like nuclear scan, angiography, D-dimers for the diagnosis of pulmonary embolism. But in our center, the most diagnosed, most preferred is CT angiography, which gives a fairly accurate results. But here also a technique is important. We have another video in which we have mentioned a technique of pulmonary angiography, because if a good technician cannot catch proper phases, a pulmonary angiography can be missed. So it's a combination of good skill and a good radiological eye to diagnose it and a clinical suspicion, of course. Now, venous thromboembolism is a major cause of pulmonary embolism, which can be diagnosed with the ultrasound, which can be repeatedly done, which can be easily available in the center, therefore should be used. Then treatment for both pulmonary embolism and DVT can reduce the risk of recurring diseases, so also morbidity and mortality. With that, I thank you for giving me your valuable time. Please note, radiology is not a race, it's a process. Be a part of this process and enjoy a feast of knowledge. Keep in mind false positive, false negative, when to suspect, which investigation to done. That will give patient the best results, and it will give us a satisfaction of making a video over the topic. If you like, give us a like and subscribe to our channel. With that, I am Dr. Anil Joshi, logging off till we meet again. Goodbye, good luck and take care. Thank you.